Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
We're going to follow a logical build, kind of like constructing a building from the ground up. We'll start with the face's foundational blueprint. Then we'll see how the lips are constructed through fusion, how the tongue is assembled from different arches, and finally, how the palate closes up. To wrap it all up, we'll connect every one of these developmental steps to real-world clinical scenarios you're likely to see.
So first things first, the blueprint. To understand the finished product, we have to rewind all the way back to the very beginning, that critical 4th week of development. This is where you'll find the 5 fundamental building blocks that create the entire facial structure. I want you to think of early facial development as a puzzle with just 5 key pieces. As you can see right here, we start with a single frontonasal prominence up top. Then, on either side, you've got the paired maxillary processes, and just below those, the paired mandibular processes. And believe it or not, every single feature of the face, we're talking nose, cheeks, lips, and jaw, it all comes from the growth and fusion of these 5 initial swellings.
Okay, so that's the surface, but what's going on underneath? This view reveals the deep framework, the pharyngeal arches. Now, each arch is like its own self-contained construction kit. It's got cartilage, muscle, and artery, and this is absolutely crucial for your exams, its own specific cranial nerve. Think of it as the zip code for head and neck development. If you understand these arches, you can decode the entire complex map of nerves and muscles in the adult face. All right, let's move to our first major construction project, the lips. And the key word, the single most important morphogenetic process you need to master here is fusion, that critical merging of the separate structures we just identified. You know, forming the upper lip is like a carefully choreographed dance. It all kicks off with the frontonasal process, growing downward. Then, certain patches of the outer cell layer, the ectoderm, thicken up to form what are called nasal placodes. These are the seeds of the future nose. Around these placodes, tissue starts to build up, creating the medial and lateral nasal processes. And then comes the grand finale, the most important step, fusion. The 2 medial nasal placodes merge in the center, and then each one of them fuses with the maxillary process from the side to complete the whole structure. This diagram really simplifies that whole process beautifully. You can see the 2 green medial nasal processes coming together right in the middle to form the central part of the upper lip, what we all know as the philtrum, that little groove. At the same time, the yellow maxillary processes from each side move in and fuse with them to form the sides of the upper lip. It's just a perfect convergence of these different parts. Now, compared to that whole complex dance for the upper lip, the lower lip is way more straightforward. As you can see here, it just forms from a simple fusion right down the midline. The 2 mandibular processes, which come from that first pharyngeal arch, they just grow toward each other and merge. That's pretty much it. Simple. So we've seen this really intricate process of fusion. And that just has to make you wonder, right? What's the clinical consequence when this complex process fails? What happens when those pieces just don't meet and merge the way they're supposed to? And here's your answer. When that fusion between the maxillary process and the medial nasal process fails, it leaves a gap. The result is a cleft lip. This slide shows the 2 main ways it can present. A unilateral cleft if the fusion fails on just one side, or a bilateral cleft if it fails on both. This isn't just a random defect. It's a direct anatomical consequence of a breakdown in that key fusion process we just talked about. Okay, let's move on to our next structure, assembling the tongue. Now, this is a fascinating story. It involves migration, it involves fusion, and it results in some very complex innervation. And the key takeaway, the secret to understanding its unique anatomy and nerve supply, is that it comes from multiple different pharyngeal arches. Before we actually build the tongue, let's just reinforce this absolutely critical concept of pharyngeal arches. Remember, these aren't just random blobs of tissue. They are the fundamental organizational units of the head and neck. Each one is pre-programmed to form very specific structures. And that's why knowing the arch of origin lets you predict its derivatives, especially its nerve supply. This principle is the key to cracking the tongue. This diagram is a fantastic map of the tongue's origins. Just look at it. Notice how the anterior 2/3 arise from swellings of the first arch, but then the posterior 1/3 comes mainly from the 3rd and 4th arches. This composite origin is exactly why the sensory innervation is so different in the front versus the back of the tongue. The adult anatomy is a direct reflection of its embryological journey. This table is absolute gold for exam review because it puts all the pieces together. Let's trace the logic.
The anterior two-thirds, it comes from the first arch, so its general sensation is supplied by the first arch nerve, the trigeminal. Make sense? The posterior third, it's from the third and fourth arches, so its sensation is handled by their nerves, the glossopharyngeal and vagus. But check this out, the muscles have a completely separate origin from the occipital somites, which is why they get their own unique nerve, the hypoglossal. So this table isn't just a list to memorize, it's the solution to the whole puzzle of the tongue's innervation.
All right, you know the drill by now. We have to ask the clinical question. What happens when these fundamental processes, like fusion and migration, go off the rails during the assembly of the tongue? This slide is perfect because it illustrates two totally different types of errors. On one side, you see a bifid or cleft tongue. This is a classic failure of fusion. The lateral swellings from the first arch just didn't merge completely. But on the other side, you have a lingual thyroid. This is a failure of migration. See, the thyroid gland starts developing at the base of the tongue, at a spot called the foramen cecum, and it's supposed to travel down into the neck. When it doesn't, it stays behind as a mass in the tongue. Two different failed processes, two very different clinical outcomes. Let's move to our final construction project, closing the palate. This is an absolutely critical step, since it's responsible for separating the oral cavity from the nasal cavity. And notice that tight timeline. This whole process has to happen, and happen correctly, between weeks 5 and 9 of development.
So how does this happen? Well, it unfolds in a few key stages. First, the primary palate forms from that fusion of the medial nasal processes we already talked about. But the main event is the formation of the secondary palate. This starts with two shelves growing out from the maxillary processes. At first, they actually hang down vertically on either side of the tongue. Then, in this really remarkable and rapid movement, they have to flip up to a horizontal position, grow toward each other, and fuse in the midline, sealing the roof of the mouth for good.
These electron micrographs are just incredible. They give us a stunning, real-world peek at this process. In image A, you can see the two palatal shelves just hanging down on either side of the tongue before they fused. Then, boom, in image B, they have successfully flipped up and fused right in the midline, forming a complete roof of the mouth. It's a truly amazing transformation.
And by now, the clinical consequence of this process failing should be pretty predictable. If those palatal shelves fail to elevate and fuse, the result is a cleft palate. This leaves an open communication between the oral and nasal cavities, and it can happen all by itself or along with the cleft lip that we discussed earlier.
Okay, let's bring it all together in our clinical synthesis and review. The whole goal here is to apply these embryological principles to solve clinical problems, which is exactly how you're going to be tested on this material.
So, what are the big universal rules we've uncovered? First, fusion is kin. The face is literally built by merging separate parts. Second, the pharyngeal arches dictate innervation. The tongue's nerve supply is a direct roadmap of its origins. Third, migration is essential. Structures like the thyroid have to travel to get to their final destination. And finally, timing is everything. These events all happen in that vulnerable first trimester. If you can master these 4 principles, you can reason your way through any question on this topic.
Let's put this to the test with a classic exam-style scenario. A patient presents with a midline mass at the base of their tongue. They also have symptoms of hypothyroidism, which means their thyroid isn't functioning well. Based on everything we've just covered, what embryological process likely failed?
And the answer, of course, is a failure of migration. The thyroid tissue never made its journey from its starting point, the foramen cecum, down into the neck. It got left behind, resulting in a lingual thyroid. This is a perfect example of how understanding the developmental journey of a structure is absolutely essential for clinical diagnosis. And that right there is the power of embryology.